Hello, everyone. My name is Frank Din, and I am the Chief Medical Information Officer and the co-founder of Fraudlens Inc. Fraudlens was designed to shift the focus of anti-fraud, waste, and abuse efforts from the pay and chase model to a prepay, pre-adjudication, detect, and prevent model. In other words, identify the fraud, waste, and abuse early and prevent the payment in the first place. This new approach requires a different way of thinking and a different set of tools. This webinar will present the things that make detect and prevent work so that you can add these ideas and tools to your own anti-fraud, waste, and abuse toolbox. This is the second of two webinars on the topic. I want to take a few minutes to review the current state of the industry just to level set for all the attendees. The current basic approach to dealing with fraud, waste, and abuse is commonly called pay and chase. That means that claims are paid and then sometime in the future, the payer finds out that they should not have been paid and tries to recover the money. Money recovery, when successful, is pennies on the dollar. This approach is used by everyone. But even with all this effort, pay and chase is stagnant. The success of pay and chase has leveled out despite increased efforts and increased funding. The Office of the Inspector General of HHS reports that fraud, waste, and abuse efforts from 2009 to 2016 shows an average of $2.56 billion per year, with the best result of $3 billion in a single year. This is a single-digit percentage success rate. I think it is also useful to do the math to see the scope of the problem. The entire healthcare market in 2012 was about $2.8 trillion. Healthcare fraud is estimated to be between 10 and 30% of the total healthcare spend. If we use that low figure, 10%, that means that $280 billion was lost. That equates to nearly $9,000 per second. Now, since the beginning of this slide, the calculator has been running. And in the approximately 30 seconds that it has taken for me to present this slide, nearly $270,000 has been lost. If you implement all the things in the previous webinar, we have shown that 7.4% of your current total payout is available. But since each instance of small fraud, waste, and abuse is not suitable for recovery, the next question becomes, how can we do something about it? How can we keep the 7.4% to fund other initiatives, reduce premiums, reward the good providers, and bend the cost curve? After all, 7.4% of $2.8 trillion is $207 billion. Imagine what good can come of $207 billion. In our previous webinar, I described the analytic tools that we need to get beyond pay and chase. Since the focus of the detection process is different, the results that we expect, that is, the measure of success, must also change. The new process is ideally suited to stopping the payment of fraudulent, wasteful, or abusive claims in the first place. Thus, the goal is to prevent instead of recover. In order to prevent fraud, waste, and abuse, we need to shift from threats of punishment to continuous pressure that influences a change of behavior. Threats are meaningless at small dollar amounts. No district attorney will spend resources to prosecute a healthcare fraud case of $200. But we can use the evidence of small dollar bad acts to show the bad actors that we know what they are doing, we are able to find the bad act every time, and we will point it out to them promptly after each bad act. The message that we use to communicate this starts benignly and escalates in tone and terseness over time. And while there is no threat of punishment in the early messages, eventually we reintroduce the threat of punishment when it becomes obvious that the non-threatening messages have failed to get the bad actor to stop. In other words, we send immediate alerts that are sent after each bad act that increases in tone over time until the bad provider stops, or we refer his cumulative bad acts for enforcement and punishment. Behavior change is not a hard and fast cookbook recipe process. Rather, it is a combination of the science of behavioral economics, as developed by 2017 Nobel Prize winner Richard Thaler, the science of persuasion by Robert Cialdini, and the lessons from actual behavior change successes in healthcare. Together, they guide us in how to implement behavior change in dealing with fraud, waste, and abuse. We start by looking at Thaler's work on behavioral economics. There is no way that we can comprehensively cover the lifetime of research that earned Richard Thaler a Nobel Prize. Instead, I will discuss only those principles that are pertinent to anti-fraud, waste, and abuse. The primary insight in behavioral economics is that people are often irrational. Conventional economic theory assumes that people make logical and rational decisions. For example, if there are two brands of the same product, like Crest and Colgate toothpaste, the purchaser should buy the toothpaste that costs the least. After all, there is no material difference in the product or its benefit. But in reality, people will often choose the brand that is more expensive. Reasons include, but are not limited to, I like the Crest logo, or my family has always used Colgate. The next consideration should not surprise anyone. Immediate satisfaction is a greater influence than a future benefit. This explains why it is so hard to stay on a diet or to save for retirement. The satisfaction from eating a Twinkie is immediate, while the prospect of maintaining a healthy weight is too abstract to serve as a motivation for not eating the Twinkie. The same applies for the satisfaction of buying new clothes instead of saving for retirement. Another key insight is that people find avoiding risk more powerful than material gain. In other words, people prefer to avoid losing $200 than winning $20. That is why it's easier to get someone to bet $2 on a 50-to-1 shot than it is to get that same person to bet $100 on a 1-to-1 favorite. They will both pay off $100 with a win, but in the first case, the loss is only $2, while in the second case, $100 is put at risk. The $2 bet avoids the downside risk. This risk aversion also applies if the possible win exceeds the possible loss. For example, if the odds on the $2 bet is now changed to 40-to-1, the gain is only $80 as opposed to a $100 gain on the $100 bet. Most people will still choose the $2 bet. In order to get people to be more rational in their decision making, we should use paternalistic libertarianism. This means that we should allow the people to make the irrational decisions if they want, but that we can influence that decision through guidance. In other words, we nudge the people into choosing their best option. This is done through education, advertising, and setting up of default choices. A real-world example of the use of behavioral economics is the anti-smoking campaign designed by Dr. Volk. The success rates of typical smoking cessation programs are dismal. It is very hard to quit, since satisfaction from the nicotine rush is immediate, while the prospects of a healthy old age is too far in the future to serve as motivation for not smoking. So Dr. Volk devised a smoking cessation program that offered a reward of up to $750 for quitting. The longer the person quit, the more money he made. The result is that smoking cessation jumped from 5% to 15%. Further, 9.4% remained smoke-free after 18 months, as compared to 3.9% with the non-incentive group. The total ROI was calculated to be $3.27 for each dollar spent. While these are great improvements from the original non-incentive results, Volk added a modification in which the participants put up their own money as well as the reward. The participants stood to lose their own money if they failed at smoking cessation. By adding this risk aversion component, smoking cessation increased to 52%. The lessons learned? Incentives work, but the incentives must be sufficient to induce participation. There is a positive ROI to behavior change. Putting skin in the game yielded the biggest result due to risk aversion. Dr. Robert Cialdini investigated a related topic that focused on psychological factors of persuasion. Persuasion is defined as the ability to get your audience to agree with you. His studies showed that there are 6 keys to persuasion. They are reciprocity, scarcity, authority, consistency, liking, and consensus. By adhering to these principles, the likelihood of getting your client to act the way you want increases dramatically. Essentially, These are the core principles that allow you to better sell your ideas or product. Reciprocity is the act of giving something to your client so that he feels an obligation to give something back to you. Most of the audience has personal experience with this principle. If your friend comes to your party, you feel an obligation to go to his party. The effectiveness of reciprocity is shown in increased revenue in a study on restaurant tipping. In every restaurant, the waiter or waitress will present the bill for the meal to the diners. In some restaurants, the food server presents the bill along with a small after-dinner mint. The act of giving this mint, the giving act, is met with a 3% increase in tip, the reciprocal act. When the food server adds a second mint, the tip increases 14%, a more than 4x increase. If the server personalizes the act of giving 2 mints by first giving 1 mint, starting to walk away, stop, return to the table, and gives a second mint along with a compliment like, "You were such great customers, I am giving you a second mint," the tip increases 23%. This personal touch increases the tip 8 times over the single mint. In this case, the increase in tips is due to the giving of the gift and adding an unexpected personalization. Scarcity is the lack of something. Knowing that something is in short supply makes people want it more. Most of you are familiar with wanting to go to a concert, only to find out that the concert is sold out, and that the only way to get a ticket is to find someone who is willing to sell their ticket at a much higher price. The lack of tickets and the desire to go to the concert is what allows the ticket seller to get a much higher price. In a real-world example of this principle, the supersonic airliner, the Concorde, used to fly across the Atlantic twice a day. British Airways was losing money on every flight since the plane flew with low passenger counts. When British Airways announced that they were reducing the flights to 1 per day, ticket sales increased immediately. The reduction to 1 flight a day made the Concorde flight a scarcity and thus the immediate increase. To leverage the scarcity effect, you should be sure to convey the benefits of what you offer, why your offering is unique, and what the customer stands to lose due to the scarcity. The Concorde example meets all these criteria. The benefit is the shortened flight time. It is the only way to experience the shortened flight time, and without the Concorde, the transatlantic flight will increase to 8 hours from 3.5 hours. People tend to follow and believe credible and knowledgeable experts. This applies even if the expertise is unproven, uncertified, and self-referential. Physicians who introduce themselves as doctor are automatically accorded an elevated status even though there is no outward proof of their title. And their opinions, especially on healthcare topics, carry more weight than the opinions of non-doctors. Authority is supported by things like a uniform with rank insignias, diplomas and awards on the wall, and name-dropping of famous experts. Each of these and other similar displays are general reminders of expertise. The authority carries even more weight if it is pointed out by a third party. In a study of real estate agencies, having the receptionist cite the expertise of the agent yielded a 20% increase in appointments and a 15% increase in signed contracts. The expertise citation was merely a public relations statement that the agent has multiple years of experience or specializes in these types of transactions, etc. Consistency is the act of asking for small, easy-to-make commitments. Instead of asking for the ideal, ask for and get a first step. Then leverage that commitment into a larger commitment until you reach the final goal. In an effort to get a community to help in a public safety campaign, very few people agreed to put big signs on their lawn. However, when the people were asked to place a small sign in the window of their house that contained the exact same message as the large sign, many more people agreed to the small sign. More importantly, after the small sign was in the window for a while, they were asked to put up the large lawn sign. The acceptance rate of going from the small sign to the big sign was 4 times better than asking to put up the big sign as the first step. People like to do business with people they like. The 3 main factors in liking someone are: 1. People like people who are similar to themselves. You can connect through school, neighborhood, sports team, or anything else in common. The actual subject matters less than the desire to share the common experience. 2. People who genuinely compliment the other party. This is not complimenting someone on their tie or their dress. This is a compliment on something of substance. A compliment on an article written, an insightful comment, or an act of kindness are all examples of substantive compliments. 3. People like people who cooperate with us on mutual goals. An example is helping your daughter sell Girl Scout cookies. The other parents and their daughters appreciate the help. Each of these makes business an extension of the personal relationship. Consensus is the tendency for people to want to be seen as part of the larger group. One of the manifestations of this is that people often wait to see how others react before deciding on what to do. Essentially, they follow the crowd. Sometimes this is called peer group pressure. In a study to see how consensus can be leveraged to persuade people to do the right thing, a campaign was launched to get customers at hotels to reuse their towels. The act would significantly save the hotel money, but equally important, the reuse of towels saved money. Normally, 74% of people will reuse their towels at some time during a hotel stay. The hotel started with a simple message on a card in every bathroom that stated, "Protect the environment." This simple generic message increased reuse 33%. When the message was changed to add, 74% of people reuse their towels, the results improved another 26%. When the message was once again changed to state 74% of the people who stayed in this room reuse their towels, the results increased another 33%. The biggest increases came from the messages that indicated that the consensus was to reuse the towel. And the more local and personal the message, like 74% of the people who stayed in this room reuse their towels, the greater the effect. The lessons that we take away from Dr. Cialdini's work is, each of the 6 principles has the ability to persuade people. It is the end user's job to leverage as many as possible. Psychology is a powerful tool to use to effect a positive change and is especially useful when the monetary benefit of the change is amorphous or geared toward a common good rather than a personal gain. One of the major problems in healthcare is the problem with nosocomial or hospital-acquired infections. In the Institute of Medicine's To Err is Human report in 2000, the researchers estimated between 44 and 88,000 patients die each year because of hospital error, and the biggest error is the spread of bacterial infections. In theory, these infections should not be that big of a problem. The simple act of hand washing before and after every patient contact should stop 95% of these infections. In fact, for a hospital to be certified, the certifying organization, JCAHO, or the Joint Commission on Accreditation for Healthcare Organizations, sets the standard for certification at 90%. In this particular case, Dr. Bender, a former chief of staff at Cedars-Sinai, knew that the hospital was going to fail at this measure. The likely failure was due to the doctors, who are oftentimes the worst offenders. Big deal. The solution is simple. Just get the doctors to wash their hands, right? Like many things in healthcare, what is simple on the surface is actually quite complex in reality. First of all, sinks were always inconveniently located. Secondly, the doctors do not believe that they are the problem. They actually believe that they are compliant with the best practices in hand washing. Thirdly, arrogance. Doctors cannot imagine that because of their exalted stature in the medical hierarchy, that they are the problem. The first issue about sinks was handled by adding alcohol-based dispensers, but this was not enough to meet the JCAHO standard. In addition, the hospital sent emails, faxes, etc., to remind the providers about hand hygiene. This was still not enough to pass JCAHO. To deal with the laggards, the hospital began offering bottles of Purell in the parking lot and handing out $10 Starbucks gift cards for eyewitnessed hand washing. This was still not enough to pass JCAHO. Finally, the hospital had the doctors culture the bacteria on their hand and a picture of the resulting bacterial growth was taken. The photo was then shown to the providers and also used as a computer screensaver for the hospital. Further, the names of the doctors who were non-compliant were placed on a crap list, and this list was available to the entire staff. These obvious, personalized demonstrations of the problem succeeded in getting compliance to nearly 100% and maintained compliance at nearly 100%. Here are the lessons that we learned from this case. Positive reinforcement works better than accusation and punishment. Additional disinfection stations, communication reminders, and the $10 gift cards got the compliance most of the way to the goal. Messages must be consistent and ongoing. Compliance patrols handing out disinfectants and $10 gift cards are an example of that ongoing effort. Single shots do not work. The goal must be transparent to all, and the difference between good and bad must be clear and distinct. Personalizing the message, continuous effort, and peer pressure works. This is evidenced in the screensaver and the crap list. The previous slides show that there is a justification for using strategies other than punishment to achieve a goal. They also show that these gentler and kinder approaches have shown success when the status quo has not achieved the desired results. When you apply these successes to the fight against healthcare fraud, waste, and abuse, similar dramatic results are achievable. The reason that fraud, waste, and abuse losses are so high is not because of master fraudsters. There are not 280 Professor Moriartys out there scamming $1 billion each. But there are 1 million healthcare providers and a small but significant percentage of them who are committing small bad acts routinely. So making a small impact on 1 million providers can make a big overall impact. Let's do some math. 100,000 providers who overbill $100 per week for 52 weeks is $520 million. If we can achieve a minimal behavior change to get them to slow down to overbilling $100 every 2 weeks for the same 52 weeks, the loss is $260 million. The small individual success saves $260 million that is now available for other things. Combining the information I have discussed in the earlier slides, the advantages of using the lessons of psychology, behavioral economics, and persuasion to affect behavior change should be evident. These are the most important advantages. Behavior change is effective. The previous slides all show examples of the success. Behavior change presumes honesty and thus avoids the provider-relationship friction associated with enforcement and punishment. Behavior change is a face-saving mechanism for the providers. It allows the bad providers a way out of the situation with no permanent negative consequence. Behavior change separates the opportunists and the marginal criminals from the hardcore. Only the hardcore will completely ignore the constant detection of fraud, waste, and abuse, as well as all attempts at behavior change. Any change in behavior is due to an internal decision by the provider and is not imposed from the external authorities. Voluntary internal change is more likely to be permanent as opposed to a forced change. It is the difference between an alcoholic who chooses to attend Alcoholics Anonymous and the alcoholic who attends court-ordered rehabilitation in prison. To achieve behavior change, we follow the 5 A's. They are assess, advise, agree, assist, and arrange. I will address each of these as they pertain to fraud, waste, and abuse. The 5 A's of behavior change were originally formulated to help people adopt healthy behaviors as a collaborative process between the doctor and the patient to achieve compliance with healthy acts. The patient is the main beneficiary of the behavior change, like better health, not the provider who formulates the 5 A's. We need to make some modifications to the 5 A's for fraud, waste, and abuse because the providers are unlikely to be collaborators and the main beneficiary is the insurer who formulates the 5 A's. After all, we are saying that the provider is doing something wrong. This list shows what each of the 5 A's mean in the context of anti-fraud, waste, and abuse efforts. Assess means that the first step is to determine what fraud, waste, and abuse has occurred. Advise means that we have to be clear, specific, and personal when we articulate what is wrong. Agree means that we need to get the provider to accept and acknowledge the fact that he did something wrong. We achieve this by producing detailed and fully transparent reports of what was found so that the provider can determine that this finding is accurate and the product of undeniable evidence, not just a lucky guess. Assist means that we need to provide a path toward resolving the problem. Arrange means that we need to be diligent in following up on everything. We need to monitor both successes and failures and celebrate the successes and ameliorate the failures. Specific to fraud, waste, and abuse, the assessment step must provide all the details of the actual fraud, waste, and abuse. This means that we need to be able to state the who, what, when, and where of the fraudulent event. It also helps to understand the how and the why. When we consider how to execute on the remaining 4 A's, it is important to consider the approach we take. I have already discussed the major move away from punishment to behavior change. But within behavior change, we need to consider some finer points. Should our messages focus on appeals to morality, like, this harms a patient and how can you justify patient harm? Or education, like, these are the most current guidelines for the proper treatment? Or guilt, like, fraud takes money away from people who really need the help. In addition, we need to make sure that the language and the tone of our messages match the approach we take. The language for education is different from the language for guilt. There are 3 main components to the assessment. We need to identify the problem. We need to understand how the fraud, waste, and abuse was perpetrated. And lastly, we want to know how it was detected. The first step is to identify the actual fraud, waste, and abuse. I discussed the new approach to detection in the previous webinar, but even the current older methods work. The key is to clearly identify the specific problem. This is because it is very difficult to affect behavior change if we do not know the specific behavior that we want to change. For example, we should want to stop smoking rather than seek healthier living. The first is a specific behavior change. The second is so general that it may involve multiple behaviors simultaneously. The assessment should also include the method of the fraud. Is this a case of phantom treatment? Is this an upcoding of an existing procedure into a higher fee procedure? Is the treatment done with no justification for the procedure? Did the provider separate a treatment code into its component parts just to increase the payment? We also need to understand how the fraud, waste, and abuse was detected. What method was used? This is a list of a couple of some of the more common detection methods. You are probably familiar with some, and the others are covered in my previous webinar on detection. Now that we know the problem, we also need to tell the provider about the problem with full details and supporting documentation. This must be done as soon as possible after the detection of the problem. Behavior change is most effective if the remediation effort occurs immediately after the event, while the bad act is still fresh. Anyone who has trained a dog knows that the reward for sitting, roll over, etc. must occur immediately after the dog does what you want. The same immediacy applies to fraud, waste, and abuse. Now that the provider is notified of the problem, we need him to acknowledge the problem. The provider reviews the notification and the supporting documentation so that he can conclude that the finding is real. Details and transparency are critical so that there is no question in the mind of the provider that the detection is correct. Now that both sides agree on what the problem is, we need to provide a path to fix the problem. That is, what is the path to behavior change? The path we choose is dependent on the context of the actual problem. How long has this been going on? Has the problem escalated over time? Is this recidivism? Is this just a question of money, or does it involve real patient harm? These are all considerations when charting a path to resolution. Because the goal is behavior change, the only constraint is that the path should be more carrot than stick, and that there should be no repercussions if the provider follows the path. This sounds obvious, but the path to resolution should be from bad to good. the endpoint should be the ideal that we seek. So if the problem is phantom patients, the endpoint is getting the provider to stop submitting claims for phantom patients. If the problem is upcoding, the endpoint should be getting them to stop upcoding. If the problem is no diagnostic justification for the treatment, the endpoint is having the diagnosis match the treatment. If the problem is unbundled services, the endpoint is restoring the bundle. The last of the 5 A's is arrange. This means that we need to establish a way to execute the behavior change and monitor the change. Since the goal is to have the provider fix the problem, there are 2 issues of concern. First, how do we know that the change has occurred? And secondly, is this a lasting change? Knowing that change has occurred can be done explicitly or implicitly. The explicit can be as simple as a formal written acknowledgement by the provider that the bad acts will no longer occur. The implicit is the disappearance of the bad acts from all future claim submission. The same process that detected the problem will also detect the lack of a problem. Now, the very observant in the audience will recognize the fatal flaw in the explicit process. How can we accept the promise of the provider? What is there to stop him from saying he has changed, but in actuality he continues to submit bad claims? The reason this scenario is not a problem is because the same detection process that discovered the problem in the first place will still be able to detect the problem if it continues. Hence, we can afford to accept the promise at face value. An extension of this is that by monitoring both the problem and the lack of a problem, we can establish a reward program to benefit the good providers. The 5 A's of behavior change that I have presented usually deal with personal behaviors. Because we have adapted these principles to anti-fraud, waste, and abuse, they are incomplete. In order to deal with the difference, we need to add 3 more components to the 5 A's. The additions are alacrity, defined as the speed at which the steps are executed; ascend, defined as the ability to escalate pressure towards behavior change; and a test, defined as the ability to move the effort from behavior change back to enforcement and punishment. Speed is of the essence. I touched on this in the slide on advise, but this issue is important enough to warrant its own A. The longer a problem lingers, the less likely there will be a resolution. Just think about the last time you cleaned out your garage. Out of sight, out of mind. Further, the time it takes to go from problem to resolution is calculated in lost dollars. Therefore, we want the time between problem identification to behavior change to be as short as possible. If you have discovered a problem that results in a $100 loss per day on January 1, and you are able to stop it on day 7, you lose $700. If you stop the provider on day 90, you lose $9,000. Multiply the $8,300 difference by 100,000 providers, and the total loss due to the delay from 7 days to 90 days is $830 million. We cannot control when the provider will respond, but we can control how fast we can detect the problem, inform the bad guy, escalate the pressure, and respond to any communication from the bad guy. Each of these is under our control and can be executed in near real time. Every successful study on behavior change has one common element. The messages that are used to achieve behavior change escalate in both content and tone. The exact same message repeated ad infinitum will plateau and then become ineffective. Because we are seeking behavior change, the initial messages should be innocuous in tone. However, if the provider does not exhibit change within a set time frame, the messages need to change to become more serious, more imminent, and more aggressive. This escalation should increase at each step until it is obvious that the provider is willingly ignoring any attempt at behavior change. The last A is attest. With all this effort, there is still a group of providers who will never change their behavior. In such cases, everything that we have attempted to do, the entirety of efforts at behavior change, should be packaged and sent to the enforcement and punishment track. These are the people who do the current pay and chase process. They will take the behavior change documentation to begin an investigation with a major head start over the typical pay and chase method. First, the investigator starts by laser focusing on the fraud, waste, and abuse that we have found. So there is no fishing expedition in the beginning, like most typical pay and chase investigations. Second, and more importantly, the failure of the behavior change effort is evidence of intent to commit a crime. The behavior change documents show that the insurer has tried numerous times to resolve the problem and that the provider has ignored every attempt. The provider cannot claim that he did not know. The major difficulty in healthcare fraud prosecutions is proving intent. These documents can only be interpreted as intent. This means that the provider is more likely to seek a plea bargain rather than lose at trial. So the initial 5 A's plus the 3 A's that we added results in the 8 A's of behavior change for healthcare fraud, waste, and abuse. Assess, advise, agree, assist, arrange, alacrity, ascend, and attest. Let's see how these ideas can be implemented in a typical case example. For the assessment, the fraud, waste, and abuse that we are looking at is unjustified full-mouth dental x-rays. I choose this example because it is a low-dollar procedure, hence not targeted by the typical pay and chase processes. The less than $100 charge for the x-rays is too low to make it worthwhile to deal with using typical pay and chase methods. This is discovered through claims analysis using the techniques discussed in the first webinar. So we have evidence and documentation to support the determination of non-justification. As soon as possible, the bad doctor needs to be told about the problem. A first-level, non-accusatory message is sent. In the message, any reference to the bad act should be linked to a simple honest error, like a clerical error or outdated coding reference. These findings should be detailed in a transparent report along with the supporting documentation. It is also helpful to include a refutation of the typical counter-argument. In this example, the typical pushback from the provider is, the last full x-rays were taken 2 years ago, and full x-rays have always been covered every 2 years. The report should include as a denial consideration, the current guidelines disallow the taking of full x-rays based on time lapse alone. There must be clinical justification. The goal is to give the provider all the information that he needs to make the determination that he is in the wrong. As part of the communication, a way to resolve the problem should be included. We want to give the provider a specific way to resolve this. In most cases, it is just a suggestion to review the claim, correct the error that we found, and then resubmit the claim. A combination of these 4 steps constitutes the behavioral economic nudge towards behavior change. Once the nudge is delivered, it is up to the provider to change or continue as before. We continue to process the claims to see if the x-ray problem continues or ceases. If this monitoring shows no change in behavior, we repeat the first 4 A's with escalating messages. At all escalation levels, the messages need to be delivered as soon as possible after the act, that is, near real time. Any communication from the provider will also need to be handled in near real time. Any changes in status needs to be changed in near real time. Behavior change is most successful when the bad act and the notification are closely linked in time. Further, the faster these things are done, the less time there is for providers to build up resentment. After a few instances of bad claims for full-mouth dental x-rays, the message needs to escalate. For example, an escalated message may include language that states that every x-ray adds to the total radiation dose absorbed by the patient, and that increases the potential harm to that patient. The messages should always be consistent with the escalation level. This slide shows a 3-level escalation. Eventually, there will be providers who do not change their behavior. For those, we need to rely on the current enforcement and punishment track. We first notify the providers that all efforts at correcting the problem as an honest error have been unsuccessful. If the pattern of unjustified x-rays continues, we will have no choice but to submit all the evidence to the enforcement authorities. This includes, but is not limited to, actions like removal from the preferred provider network, a halt to all claims processing from the provider, and a full audit. In the last few slides, I have discussed how to implement the 8 A's of behavior change. In the earlier slides, I presented you with the foundation of the process. I am now going to link the actions to the theory. From the behavioral economics discussion, we can see that the provider who ignores fraud, waste, and abuse detection is acting irrationally because, by ignoring the warnings, the provider puts his career at risk. The money received from successful fraud, waste, and abuse provides a near-term benefit that supersedes any long-term consideration. More money now is better than developing a long-term reputation as an honest provider. With escalating attempts to affect behavior change, the threat of loss of license exceeds the immediate benefit of the money from fraud, waste, and abuse. The potential loss of license is the skin in the game component of behavioral economics. The escalating messages are the nudge. In this slide, I link the 8 A's with the basic foundation of persuasion. The early non-accusatory alert messages incorporate elements of reciprocity, authority, consistency, and liking. The authority and liking comes from the details which show that the detection is from a fellow dental professional. The consistency is that suggested corrections is a small act and that by agreeing to the small act, all the problems are solved. The reciprocity is evident in the offer of a simple correction to resolve the problem. The detailed reports show authority, consistency, and consensus. The authority and consistency are as described above, and the consensus is evident in the report that shows that the bad act is an outlier to the other providers. If we extend the anti-fraud, waste, and abuse analysis to include an analysis and ranking of the good providers, we touch on all 6 components of persuasion. The really interesting part of using behavior change as your path to success is that there are ancillary effects in addition to the direct effects. They are network effects, adherence to best practices, ranking of good providers, and refocusing staff. I will touch on each briefly. Network effects means that the effectiveness will extend beyond those who are directly impacted. In other words, even providers who do not receive any alerts will know of providers who have. This knowledge will put those unaffected providers on notice that the behavior change mechanism is now being implemented, and that it is only a matter of time before they are subject to this process. So it is to their benefit to stop submitting claims that are likely to be caught. Furthermore, this may also reduce the submission of fraud, waste, and abuse that is not currently targeted. The opportunists will not want to risk their license to practice knowing that the monitoring and alerts are ongoing and growing. Since many of the detection methods are based on best practices, the success of behavior change will increase the number and the percentage of providers who adhere to best practices. This is a less preachy way to improve compliance with best practices. This is also a way to score the provider in terms of clinical quality. If we know the scores and rankings of the best doctors, insurers can devise incentive and reward programs for the good providers. This includes, but is not limited to, appreciation ceremonies and awards, cash rewards, and preferential choice in customer referrals. As the instances of small fraud, waste, and abuse decreases, the current staff that deals with fraud, waste, and abuse can be dedicated to dealing with complex frauds or other needs where human insight is needed. Here is my contact information in case you have any questions, as well as my LinkedIn profile where you can find links to full scientific papers and presentations that touch on this and other related topics. I thank you for your time and your attention.